بسم الله نبدأ دكتور محمد.
بسم الله الرحمن الرحيم. Assalamu alaikum everybody, and welcome to all attendees today in our first symposium in the cardiology. We are making this symposium through our hospital, Saudi German Hospital in Madinah, Saudi Arabia. It's my pleasure to be the moderator for this symposium. Me and my colleague, Dr. Ahmed. We have in this symposium talking about the acute coronary syndrome. As you know, everybody, we have newly guidelines every day and every hour about the cardiology. We are in the marathon of the guidelines regarding all topics of cardiology. So we should be updated by these guidelines. We should do our practice according to the international guidelines. So we took in our shoulders to make this symposium. It will be regularly, inshallah, to take each topic and to see the new guidelines related to this topic. Our symposium, the first one, we will talk about the acute coronary syndrome, different topics about STEMI, non-STEMI acute coronary syndrome, unstable angina, even the intervention with the bypass surgeries. What is the role of surgery in the cases of acute coronary syndrome? So we will enjoy together in this symposium. Also, we have in this symposium a good collection of the famous professors in our career cardiology. We will enjoy together with these topics. It will be small topics, short topics. We will touch the topic in easy way. And anybody has any question, we can share the question through the Zoom. And we will take these questions later on after we finish the symposium. Today we have two topics. The first one will be with Dr. Osama Al-Hadrami. Dr. Osama Al-Hadrami is a professor of cardiology in Taiba University, one of the pioneers of the intervention cardiology in Madinah and Saudi Arabia. He is consultant cardiology in Saudi German Hospital, and he had different and several certificates related to cardiology and the intervention cardiology. So we will start our topic with Dr. Osama. Second topic will be with Professor Dr. Ashraf Fawzi. He is a consultant cardiothoracic, professor of cardiothoracic in Cairo University. And also he is a consultant and the head of department of cardiothoracic in Saudi German Hospital, Madinah. I would like to welcome to all attendees today with us. And I will let Dr. Osama, Professor Dr. Osama, to start his topic. Then we will take the another. You can proceed, Dr. Osama.
Assalamu alaikum wa rahmatullah. It's my pleasure. I really like to thank the organizing committee and the Saudi German group for giving me this opportunity to participate in this meeting, and I hope that we can, inshallah, do more of this in the near future. So my task today is to give you an update about what we used to call in the past non-ST elevation myocardial infarction. Nothing really to disclose. So all my topic is based on the most recent updated guidelines from 14, the ACCHA 2014 and 15, and then the most recent update of the European Society in 2020, just last year. So the first update that I'd like to let you know about is that we are not going to call this condition anymore non-ST elevation myocardial infarction. All right, so now the guidelines shifted gears, and now we are going to call it non-ST elevation acute coronary syndrome or non-ST elevation ACS. And I'm going to tell you why and what are these definitions. So ST elevation MI has a very specific diagnosis. A patient comes in with typical chest or comes in with chest pain and persistent ST elevation for 20 minutes. Someone meets this definition, this is STEMI, easy. Now, the non-ST elevation ACS is basically everything other than ST elevation MI. And that's what we included before the two groups of non-ST elevation MI and unstable angina. But you will see some change here in the definition. So now non-ST elevation ACS, the patient comes in with chest pain with any one of the following items. So if there is a transient ST elevation more or less than 20 minutes, because if it's more than 20 minutes, we're going to call it STEMI. If there is ST depression, T-wave inversion, flat or inverted T-wave, and even people coming with typical anginal pain and with normal ECG. So what is striking here that you don't see any troponin or release of myocyte or cardiac enzymes in the circulation that we used to call and diagnose before. And I will tell you why the troponin has been removed and it is used for what reason in the next few slides. So this is a traditional slide that we teach all the time when we talk about acute coronary syndrome. So in the right, there is a thrombus. Clot includes the complete coronary artery. It results in ST elevation that is more than 20 minutes. It is ST elevation MI. So any thrombus or clot that partially occludes the artery. So you see still some lumen clot mean diameter around this thrombus. These people are very unlikely that they will present with ST elevation MI. So these are the people who either we used to call unstable angina or non-ST elevation MI, based if there is any release of troponin in the circulation. But now nowadays we call them non-ST elevation ACS. So the only difference is now the presence or absence of ST elevation or persistent ST elevation, to be more specific. So these are the ST changes that we covered in the definition: ST depression, horizontal, downsloping, and upsloping. And we know that the most specific ST depression for ischemia is the horizontal or the downsloping. The upsloping is very poor marker of ischemia. This is what we see most of the time during the stress test. And of course, T-wave inversion or changes of T-wave are a very horrible way of identifying ischemia, yet they are part of the definition. Now, I usually present this slide whenever I talk about non-ST ACS. That unfortunately, I just get this example that we as a cardiologist have a lot of respect to STEMI, yet we underestimate non-ST elevation MI. We don't have a code for non-STEMI. Like STEMI, even the ambulance can activate the cath lab in some hospitals. But in non-STEMI, these are the people who are unfortunately missed, not recognized early. And to prove this, many studies in the past, like starting from the 90s, compared the outcome of patients presenting with ST elevation MI compared to non-ST elevation MI. And this is the number of years of follow-up. So it's not only short-term mortality, but it's all the way up to 8 years mortality. The non-ST elevation MI patients have much more worse outcome compared to ST elevation MI. And this is also, as we said, I mean, this is applicable in the long term and the short term mortality. I mean, short term mainly within 30 days, and in more than that for the long term survival. And this is not only related to the risk factors these people have. So we look at STEMI outcome in non-diabetic patients compared to non-ST elevation non-diabetic patients, so both group non-diabetic, and you can still see that the survival of non-ST elevation in non-diabetic patients is also worse than the survival of ST elevation in MI. And of course, diabetes, it goes without saying. So non-ST elevation in MI, we do very poor compared to ST elevation in MI. Why this is happening? The reason, sorry, this has to play, but I was unable to play it. Now I'm just showing you a picture of, this is a patient I had just last week, non-ST elevation, and you can see a very nasty multivessel disease, including the ostial LAD, mid-LAD, and circumflex. And this is a lady with type 1 diabetes. You see here a very tight circ, very tight LAD. Not only that they have a lot of multiple lesions, but revascularization of these people is very tricky. This is a patient who I spent almost 1.5 hours to try to open the right coronary artery, which was heavily calcified. I started with like a 1.5 balloon, and because I was unable to pass anything more than that. And this is after revascularization. So compared to patients with ST elevation, where they have just nice, clean arteries, and they only come with culprit lesions. So this patient has just an occluded circ. You open it, and you will see very nice, clean arteries in the other territories. So to make sure that we are not missing the diagnosis or to miss these people, we have to go all the time revisit our fundamental. We have to know the basics. The most critical step for us to recognize these people is to go to the pathophysiological definition of anginal pain. So it is a pure physiological definition, retrosternal chest pain, exacerbated by exertion or activity, relieved by rest or nitroglycerin. Easy. If someone meets 3 out of 3 criteria, this is typical anginal pain. If someone only meets 1 out of 3 criteria, this is non-anginal pain, and 2 out of 3 makes it atypical anginal pain. So this is the first step really for you to recognize these people. So now, who are the people who are going to present with atypical pain? Like the most famous one is a diabetic patient with neuropathy and chronic kidney disease, dementia, those with worsening shortness of breath. So I'm sure that most of you see patients with worsening shortness of breath without any presence of angina. So make sure that you cover these patients, make a very careful assessment. So now I'm going to walk you step through the protocols, what we know from the guidelines. As of this, like almost I'm going to give you an approach. How do you deal with these people from the moment they hit the emergency department until like we follow them up and discharge them in the clinic? So the moment patient hit the emergency department with this possible condition, what do we know from the guidelines? So the first ECG has to be done within 10 minutes of ER arrival, and it has to be repeated every 15, 30 minutes in 1 hour. So one ECG is not enough to diagnose a patient. So no one should go unless you have 2 ECGs. And this goes with the troponin. So the first troponin has to be done in 0 to 1 hour of arrival. 0 hour, and the result has to come within 60 minutes, and then you repeat it in 2 hours. Third troponin is only indicated if the patient is showing impressive ST changes or ischemic changes, yet has 2 negative troponins. So that would be make it a very good solid case for a third troponin. So CK&B, please are not indicated anymore for infarct or even re-infarct. It's out of the guidelines. Number 2, once you establish ECG cardiac enzyme, you have to sit, relax, and calculate the risk score of the patient. And most guidelines now recommend it as a class 1 indication in these people. So the most famous 2 risk tools assessment, the TIMI score, which has some variables, age, risk factor, ECG changes, enzymes. But the one that we really recommend, and most guidelines now make it superior than the TIMI score, is the GRACE score. Has so many variables, it's more complex, but you don't need to worry about this because all are available in, thanks God, the smartphone. We have all the applications for these. So you just put it in your app, download and tick, and you get your risk score. So now, why do we care about this risk score? The reason is that it is used when you have to do it to know the disposition of your patient. Someone going to be admitted or someone to be discharged. So yes, can we discharge patient home with non-ST-ACS? Absolutely, yes. So who are the people who can discharge home safely? So anyone with non-ST elevation and low risk ACS based on the GRACE score. So you can discharge him home. Make sure that you do a coronary CT, which is now most guidelines recommend as number 1, or stress test. Either you do it before discharge or within 72 hours of discharge. And this is most of the guidelines now that agreed on. So discharge if possible, or not more than 3 days, because after 3 days, the whole pathophysiology changes. And make sure that you put good medical therapy for these people if you discharge patients home, as I'm going to talk in the next few slides. So now pain control is something really I like to teach my student at the university about the traditional first line therapy that we were taught to do. So oxygen is only indicated if the patient has saturation less than 90%. So if you give oxygen to someone who's having anginal pain with saturation over 90%, the patient can go into arrhythmia because of the oxygen-free radical toxicity. So only if the patient is hypoxic, less than 90. Nitrate, you give it only if the patient is symptomatic, has angina. IV nitrate, you switch if the patient has ongoing pain, hypertension, or heart failure. Morphine is not anymore class 1 indicated, and if someone has or has been using phosphodiesterase inhibitor, then nitroglycerin should be completely avoided. Unfortunately, we still see some patients get non-steroidal in the emergency department for anginal pain. The most famous one is the ketorolac, but this is absolutely a wrong practice. So every time I teach the student that Mona that we used to teach you and before has died. She's not there anymore. So beta blocker, who should be getting beta blocker? So now the class 1 indication for beta blocker, that to make it easy for you, every single one should be in beta blocker unless you have one of the 3 problems: active heart failure, low cardiac output where the contractility matters in these people, and if there is heart block or advanced heart block. These are the 3 people that should avoid beta blocker. So now if you are like early use of beta blocker in these people has not been shown to improve survival. So you are absolutely welcome to wait for a few hours until you have a clear picture, but please don't wait for more than 24 hours to start beta blocker. So wait, but don't wait for the beta blocker. Of course, another indication if there is heart failure, reduced ejection fraction, and you can stop ejection beta blocker if most of the heart failure expertise recommend this is you stop it if someone recovers heart failure more than 2 years, then you might stop it, but putting it for more than that is class 2 indication. So calcium channel blocker is another common medication that we see in these people who should be getting it. Ideally, the two calcium channel blocker, the non-dihydropyridines like verapamil or diltiazem, should be spared to those who are contraindicated to beta blocker in the absence of heart failure, heart block, or blue cardiovascular. So the priority number one is beta blocker. If they are not suitable, you switch to non-dihydropyridine. Please give a chance or give a chance 1 and 2 and 3 to patients with asthma and COPD. These people, I think I just disconnected my video. So these people still benefit and tolerate beta blocker well. So don't avoid the benefit of beta blocker in these people. And of course, the most famous indication is when you have coronary vasospasm. Statins, the one that I'm sure most of you like, but unfortunately, most of us don't like the recommended dose that is in the guidelines. So the American guidelines recommend high dose statin intensity for all these people, irrespective of the LDL profile or the presence of risk factor. Please be familiar with the the doses and every single the medication, what defines high intensity, moderate, or low intensity statin. So the most famous one is the atorvastatin, 40 to 80. So 20 atorva is not high intensity. Rosuva 20 and 40. So Crestor 10 is not considered a high dose intensity. Now, the European guidelines actually use less strict guideline recommendation compared to the ACC guidelines with regard to lipid therapy. So they mention you start the maximum tolerated dose of statin. So whatever the maximum dose is tolerated, you keep the patient. So if the patient tolerates 10, you have to progress to 20. If the patient tolerates the 20, you have to progress to 40, for example. So you stop only if the patient does not tolerate the dose. Of course, guidelines recommend an LDL less than 55 in these people. And don't forget that the first agent is statin, followed by statin and ezetimibe. And if the patient does not, you didn't get your LDL control by that time, then you add PCSK9 or Repatha, for example. Make sure that you give 6 weeks at least time interval before you add another agent. So ACE inhibitor, more or less, or ARBs, more or less has the same indication as beta blocker in this group of people. So if you have hypertension, diabetes, or CKD, and those with heart failure, reduced ejection fraction. So aldosterone antagonists, again, in these people are only indicated if you have heart failure, reduced ejection fraction, symptomatic heart failure, not asymptomatic heart failure, and they have to have a creatinine less than 2.5 and potassium 5, and they already are on beta blocker and ACE inhibitor. Fortunately, we still see sometimes people getting aldosterone before getting beta blocker or even ACE inhibitor. So antiplatelet therapy. Upfront, we know that aspirin, whenever you have this patient hitting the emergency department with this possible diagnosis, upload with aspirin. Make sure that they get encapsulated aspirin. So you chew, they chew, and then they swallow. After that, once they chew or swallow, you have to add another PTY or another antiplatelet medication. And you can see here the doses, loading dose of clopidogrel, prasugrel, and ticagrelor. Now, I'm not going to cover each one of them because I think Dr. Umar is going to teach us about the antiplatelet medications. But generally speaking, number one choice, if you have someone with non-STACS going for angiogram, is prasugrel. If you have someone who is going for possible, if you are not sure whether I'm going to go for invasive or non-invasive strategy, then ticagrelor and clopidogrel is the guidelines recommend only if you give it, if you don't have ticagrelor or prasugrel. Now, if you have someone who is not going for a non-invasive strategy, so you're discharging the patient home, then yes, you might put them on another antiplatelet, and the soft really recommendation, the guidelines, and 2B. So mainly very solid if you are going for invasive strategy. So the famous glycoprotein 2B3 inhibitor. So historically, we used to give it in the early 2000 when the era of glycoprotein, and everyone was so fascinated about it. But lots of studies failed really to document or to show any benefits of these medications. So who should be getting it? So first of all, the indication, the guidelines for non-ST elevation MI is really a soft one. There is no solid. Should be getting it. Number one, or the people, mostly the people who have or who get a complication of thrombotic events during angioplasty. So if we have no reflow, or when you have a lot of plaque shift, then yes, they recommend or they benefit from it. And if you only have patients who's having refractory symptoms without knowing the angiogram of these people or without knowing the anatomy, is always better to avoid these people. That was a practice in the long time ago to give any high-risk people who are in 2 antiplatelet plus anticoagulant, you add to that a glycoprotein. It was okay at that time, but now you don't give glycoprotein unless you know the anatomy of these people. So again, anticoagulation, I'm sure it's going to be covered. Make sure that you know what you have in the hospital. Enoxaparin to load the patient with non-STACS. You have to know the loading dose. Make sure that when you deal with enoxaparin loading, make sure you give them an intravenous dose. So like we do with thrombolytic therapy. Unfortunately, lots of patients who receive enoxaparin just before shifting them to the cath lab, they do have, the studies show that might have clots in the wires, and they might have problems with stent thrombosis as well, just because they were not uploaded. So every time, make sure that you upload IV 30 milligram before you give the therapeutic dose. Bivalve loading is probably the trend, and most of the guidelines recommend to do it in the cath lab during the study, during the angioplasty, if your patient was not uploaded with enoxaparin and prochirated heparin. It's so good. So many studies show the efficacy of it, less bleeding complication compared to the traditional and short half-life relatively. So thrombolytic therapy, still the guidelines mention it, it's class 3. So you'll be surprised why the guidelines still mention thrombolytics, because unfortunately still people with non-ST elevation gets it from time to time. Particularly now, we moved from a biochemical definition to a pure electrical definition. So invasive strategy, who should be going for early, very early invasive surgery? So now two numbers you have to know. Immediate invasive strategy. So if you have someone in the ER who hit, when should I take him to the cath lab less than 2 hours? So of course, number one, if the patient is hemodynamic instability, shock, and make sure that these people are likely the shock is cardiogenic, not because of the bleeding or sepsis, for example. Life-threatening arrhythmias, or if the heart failure is refractory to medical therapy, and or if there is a very widespread ST depression in 6 leads, then these are the people who the studies have shown the benefit of early invasive strategy in 2 hours. Other than that, then if someone meets any of the following criteria in the early invasive strategy, then you do the angioplasty for them in less than 24 hours. So anyone that doesn't have a very high risk, then it's better to do it in 24 hours. Some guidelines stretch to 24 to 72 hours, but nowadays it's most guidelines recommendation class 1 is to do it less than 24 hours. So the question is, why not all to do it all in like 2 hours? Why not to treat them as the STEMI patients and open the artery quickly? The answer is because of what I have shown you, the anatomy of these people and the complexity, the atheroma that they have, the burden of thrombus they have. So you have to stabilize these plaques, you have to stabilize these thrombuses, so the patient won't have nasty complications like distal embolization or no reflow, for example. So ischemia-guided therapy, basically, this is a new terminology that is used to go for invasive, not to go for medical therapy, and only do invasive if the patient flips or shows feature of high risk. So what is, I'll give you an example. You have a patient in the ER that you, after your initial 2 hours, you deem that he's at low risk of he's a low ACS, a non-ST elevation ACS. So you are okay to discharge this patient home, put them on medical therapy, and then you have 3 days to work them up. You bring the patient for a stress test. If the patient, for example, passes the stress test, you can follow the patient closely in medical therapy. You don't need to do invasive strategy for these people. You follow them in 2-3 months. If they show relapse, then you proceed to invasive strategy. So not all patients with non-ST elevation ACS should go for invasive strategy. So this is a concept that is growing now in the guidelines. So revascularization, I think it's going to be another topic with one of my colleagues. So again, it's only culprit lesion. Multi-vessel PCI is not acceptable or might be harmful in these people with non-ST elevation ACS, even if they are in shock. Not like the STEMI patient that Dr. Ibrahim is going to teach us tomorrow might benefit from total revascularization if they are shocked. Here, the non-ST elevation people really do not show that. At least for now, that's what we know from that. So to conclude, know your patient well, categorize your patient. Risk score is extremely useful to guide your therapy and to guide your strategy in the future. Early discharge and ischemia-guided therapy is absolutely acceptable for those who are showing low-risk non-ST elevation ACS features. Make sure that when you discharge them, you follow them closely, do the screening test within 3 days, and you put them on good medical therapy, whether antiplatelet, single or double antiplatelet, depends on your clinical judgment. Invasive strategy, know the 2 hours rule and the 24 hours rule. Don't really delay them more than that. Better to do all in the 24 hours. As of yet, we deal with culprit vessel PCI in these people. So thanks so much. I conclude, and we'll be happy, I believe, some discussion or answers after Dr. Ashraf's talk. Thank you.
Thank you so much, Dr. Osama, for this nice presentation. We really enjoyed by this topic, and you didn't let any point related to the treatment, and you discuss it in details. Thank you, Dr. Osama, and please, for all colleagues, anybody has any question, please write it on the Zoom panel, so we can take this question later on after the second presentation. Thank you, Dr. Osama.
Thank you, Dr. Osama. Thanks really to all of you. You know, in my Twitter account, feel free to contact me, or because I do some also post some teaching things or share some cases as well, just for education purposes. So feel free.
That's great. Follow. That's great, Dr. Osama. Thank you.
Thank you.
Okay, everybody. Now we will go for our next presentation. It will be presented by our professor, Dr. Ashraf Fawzi. As I said before, he is one of the pioneers in cardiothoracic surgery related to the bypass surgery. He is one of the small figures that doing bypass surgery through beating heart technique without cardiopulmonary pump machine. We will enjoy together with him. He will talk about the role of cardiothoracic surgery in patients with acute coronary syndrome. As you know, sometimes we are facing a great problem with some cases of acute coronary syndrome, either of the mechanical complication or difficult intervention with these cases. So we will let Dr. Ashraf to share his presentation. Then we will listen to him. After that, we will collect all the questions and we will reply it one by one.
Good evening, everybody. Today, our topic, it will be under the name of parameters of CABG after acute MI. But we have other alternatives for naming this topic, like optimum timing of CABG after STEMI or non-STEMI. As you know, all early revascularization is preferred to save the myocardium after acute myocardial infarction, and revascularization could be done by PCI, CABG, or hybrid. And this should be discussed by the cardiac team in most of the centers. This is a routine work in our hospital also. The optimal timing, as we know, for coronary artery bypass grafting in patients with ST segment elevation or STEMI is not clear till now. There is no consensus for this point exactly. But we have to know a certain fact that early revascularization using PCI, however, continues to be the favored option for infarcted patients. Coronary artery bypass grafting is normally deferred for later revascularization of the non-culprit arteries in some cases. When the culprit vessels cannot be or couldn't be opened by the PCI, there is an often pressure on the cardiothoracic surgeons to operate early on these patients. And this pressure, sure, it's by the cardiologist himself. Another perceived benefit of surgery is that full revascularization can be obtained earlier and minimize cardiac ischemia and the effect of revascularization on remodeling, as all of us know. The current view on when CABG should be performed on STEMI patients is not entirely clear, and this is the point that we are going to discuss today, reminding you of certain fact. To reach to a consensus is not our target. Maybe at the end, we don't have a consensus for this point. As we know, remodeling after MI or myocardial infarction, left ventricular remodeling is a process by which the ventricular size, shape, and function are regulated by mechanical, neurohormonal, and genetic factors. After MI, the heart undergoes extensive myocardial remodeling through the accumulation of fibrous tissue in both the infarcted and the non-infarcted myocardium, which definitely distorts the tissue structure of the myocardium, or specifically speaking, the ventricle, increasing tissue stiffness and accounts for the ventricular dysfunction. Due to the degree of difficulty to study the viable myocardium in human, so all the studies which are available is by animal models. After myocardial infarction, the abrupt increase in the volume overload induces a unique pattern of remodeling in the infarct zone and bordering non-infarcted myocardium. The oxygen-deprived myocardium experiences a localized inflammatory response through a neurohumoral activation mediated in part by the migration of neutrophils, monocytes, macrophages. Moreover, there is also intramyocardial hemorrhage, and this is very important. This leads to myocardial edema and microvascular damage and change in the volume and function of the ventricles, as we said before. All this affects the remodeling process. The global left ventricular longitudinal strain and circumferential strain with feature tracking could be diagnosed by MRI. As we see here, this is a regional effect. We will not go through this in details now, and this some pictures to show the post-myocardial infarction remodeling and the change in the geometry of the ventricle. Here also it is another slide to show how the geometry of the ventricle is going to change. Here also, as we know, inadequate healing after myocardial infarction may lead to infarct expansion, left ventricular dilatation, myocardial thinning, or heart failure. Hypotension and the subsequent decrease in the cardiac output stimulate temporarily the circulatory hemodynamic compensatory mechanisms, including increased sympathetic nervous system, renin-angiotensin aldosterone system, and natriuretic peptide activity. The induction of cardiomyocyte hypertrophy is a key process during post-myocardial infarction remodeling that offsets the increase of the volume overload, attenuates progressive dilatation, and stabilizes the contractile function. Thus, the post-myocardial infarction myocytes hypertrophy initially serves as an adaptive cardiac preserving response. However, over time, chronic neurohumoral activation, myocardial stretch, and the RAS activity and various paracrine and autocrine factors continue to promote the eccentric pathological hypertrophy. Interestingly, compelling evidence has shown that post-myocardial exercise favorably influences the course of left ventricular remodeling, which accordingly has attracted much attention, and will not go through this point also. But now we have questions to answer. These questions, which is related specifically to our topic, is it urgent after STEMI to do CABG if it is indicated? Is there any relation between the level of the elevated cardiac enzymes and the risk of the outcome of surgery? Is there a consensus regarding the optimum timing for CABG? And is it a burden on the healthcare resources to delay the CABG, or is it safer for the patient and better for the outcome? Do we have parameters to use as guides for the timing of surgery? These questions are causing us a dilemma in most of the patients. So what is the definition of the optimum timing? And this is the main question to be answered. The optimum timing for CABG, it is the time frame from the onset of myocardial infarction to the time of performing CABG in which death is minimized without unnecessary increase in the hospital stay and resources utilization. By this definition, still we don't have an accurate time. As we see, there is no accurate time or parameters, knowing that 20% of the patients who had myocardial infarction are candidates for CABG. 50 to 80% are multi-vessel disease, so it is a big number of patients, so we have to take a decision in such big number of patients. In older studies or before, delaying the operation for 3 to 5 days after myocardial infarction was thought to decrease the mortality rather than doing it earlier. By the way, most of the concepts in the past have been changed a lot now. More recent studies reported no differences whether performed earlier or later, and we will say why this point is specifically changed now. The dilemma of the antiplatelets and the STEMI or non-STEMI, the criticality of the lesions, left main, not left main, recurrent or intractable angina, and the hemodynamic instability or the shock state of the patient. These also some parameters which may change our decision. All these parameters, as we said before, might change the timing, decision, and hence the outcome. We have time frames for such kinds of patients. I don't like this classification actually, but it's documented and most of the researchers are documenting this. Performing the CABG within 6 hours or within 24 hours, within 1 or 2 days, within 3 to 7 days, or between the window of 1 week or more than between 1 week to 3 weeks. The outcomes, we'll discuss now the outcomes of CABG after myocardial infarction. We have to classify them, or we have two classifications: the primary outcome, which is called the in-hospital mortality, and the secondary outcome, which is the complications. To say it, it's like reopening the patient for bleeding, excessive blood or blood components transfusion, cerebrovascular accidents, or new development of arrhythmias. So now we have many parameters sharing in the outcomes, whether it's primary or secondary. Of these parameters, which affect the outcome in the intervention by CABG in acute MI, like the age, the ejection fraction, the multi-vessel disease, left main, white blood counts, prior CABG or redo CABG, peripheral vascular disease, COPD, diabetes, renal impairment, repeated STEMI, failed PCI, preoperative use of intra-aortic balloon, congestive heart failure, surgeon experience, sure, and whether it is done on pump or off pump, and the nature of the pathology or the use of LEMA to LED or left internal mammary artery to left anterior descending. Sometimes some people, they are using veins or some other conduits, so this also a parameter affecting the outcome. Now we will discuss what is the outcome or the primary and secondary outcomes? The overall in hospital mortality in most reports is 2%. It's collective for patients done within few hours up to 3 weeks. It's 2%. It's more than 5% if it is done within 24 hours of infarction, and 3% if it is performed between 8 to 21 days of infarction, and it is 1.6 in patients operated within a window of 1 to 3 days and 3 to 7 days. So you see here it's variable, but the highest rate of primary and secondary bad outcome is if we performed the operation within a window of 1 day. So we have to conclude from this, it's either to be performed early or later if we postpone it for 24 hours for one reason or another. Anyway, the secondary outcome and the morbidity is also higher if the CABG is performed very early within 24 hours, as we said, or if we delay it more than 21 days. The same outcome is almost in STEMI or non-STEMI. It's not different between both. The difference between, or the differences in the secondary outcomes of the 5 groups, as we said, depending on the time frame, were insignificant. Generally, it's insignificant almost in all parameters except for the intraoperative need for blood transfusion and the reopening after CABG, and this is mostly due to the intake of the anticoagulants, oral antiplatelets, or if the patient is receiving thrombolytic therapy before. The rate was higher in groups operated, as we see before, as we said before, in the group which were operated within a time frame of 24 hours. Among all groups of primary and secondary outcomes were unfavorable, with intractable angina and the use of intra-aortic balloon pump patients. So if the patient is having intractable angina and he was submitted for CABG, or we're obliged to use an intra-aortic balloon pre-operative or intraoperative for such kind of patients, so the outcome is not favorable. In most of the reports, all the outcome data obtained were based on observational analysis, as there was no controlled randomized trials analysis. In some other large studies, acute coronary treatment and the intervention outcome network registry, as we see in this report, some reports documenting the results, they reported no differences in the primary outcomes, and in any of these groups. Anyway, we'll not go into details of these groups, but generally there is no major differences in the outcome of surgery among all these 5 groups of time frame. So now, what is the limitations of CABG, or doing CABG early or late or whatever within these 5 time frames? We have limitations for performing the operation, like the myocardium at risk. It might be a big area or small area, and this also is a limitation of the studies, and it's causing confusion about the result or the outcome of the CABG, like the size of the infarcted area, the troponin level, the patient frailty, the antiplatelets drugs, also delaying the decision, some administrative delays, and we should consider this because some approvals or some company approvals are delayed, so the result or the outcome will be affected by some administrative issues. Also, the surgeon and the teams or center experience in such cases, it's also affecting the outcome, and some patients were discharged. We have to notice this, and this is also very important. Some patients were discharged and not presented to the hospital. So we don't know the fate of this patient, so we cannot include them in any studies, so the result will be confusing. So the actual timing of the acute myocardial infarction also couldn't be known or identified well in most of the patients. Yeah, some patients are coming, so we have to, it's very difficult to assort them in a time frame of the other 5 groups we mentioned before. So this is some points limiting the outcomes of performing CABG in early myocardial infarction. So, despite the urgency and severity of STEMI, a delay in surgical revascularization of at least 24 hours may be beneficial to the short-term and long-term outcomes in these patients. And this is an important point. So some cardiologists or some relatives of the patients are angry why you postpone the patients while he's in a critical condition, and most of the people, they said he needs urgent surgery. No, this is dangerous and wrong. If the STEMI patient is not hemodynamically stable, then surgical intervention in the form of LV or left ventricular assisted device would be appropriate. Based on different ejection fractions also, the result will be confusing or will change from patient to patient. Anyway, now the myocardial viability is an important factor. To conclude this, myocardial viability is an important factor that affects the perioperative mortality and long-term survival of the patients with ischemic heart failure. bypass this. بس مش شايف. في some reports طبعا في in performing the CABG in 24 hours window. In some reports, the operative mortality, as we said before, is 2.2% in patients with the ratio variable of viable myocardium more than 10%. This result suggests that these patients are suitable for CABG. معلش بس انا بجري عشان الوقت. Determining whether these patients are suitable for CABG requires a joint evaluation with the cardiologist to develop an individualized treatment plan. Myocardial viability is an important factor that affects the operative mortality and complications and should be fully assessed before surgery. In terms of long-term prognosis, a series of previous studies suggested that improvement in cardiac function after CABG is common in patients with certain myocardial viability and mild left ventricular remodeling. Patients with severe left ventricular remodeling, regardless of the degree of myocardial viability, post-operative cardiac function is not significantly improved. Patients with low viable myocardium ratio and significant left ventricular enlargement have a high perioperative risk, and that patients with a low viable myocardium ratio have poor prognosis. The myocardial viability is an important factor that affects perioperative mortality and long-term survival of post-CABG. The left ventricular remodeling increase. في صوت أنا سامع صوت بس جانبي.
Please, everybody can check his microphone and mute it.
Anyway, to sum up what we said, there is no certain fixed time frame for performing CABG for all of the patients. whether he's stable or not stable, whether he's STEMI or non-STEMI, and this should be individualized for every single patient, and the decision should be taken by the heart team for every single patient. For our humble, or regarding our humble experience in our hospital in SGH Madinah, we have a conclusion or a consensus, this between me and the cardiologist in our department, that delaying the operation for CABG after myocardial infarction is not that harmful unless the patient is a left main or having a preserved myocardium or having a good ejection fraction, so we can perform these patients, this kind of patients. Again, saying that the conclusion or our conclusion, there is no consensus for the timing or the exact parameters for all of the patients who are having myocardial infarction, and it's a variable parameter decision from patient to another patient, and to be decided by the heart team, not to be generalized for all the patients. Thank you.
Thank you, Dr. Ashraf Fawzi, for this nice presentation. Again, you touched a very important points related to the intervention by surgery in cases of acute coronary syndrome. Time frame is very important for those cases. And you said that it will be different from patient to patient according to some risk factors, precipitating factors. We are facing this problem every day. When to do the surgery, delay or postpone, and what is the parameter to build your opinion
I will
about
tell you
it
is. I will tell you something. It's the parameters. We have many parameters: the hemodynamics of the patients, the clinical status of the patients, and the investigations of the patients. So, for example, if a patient is having an acute event like severe myocardial infarction with elevated enzymes, even reaching up to thousands, and the myocardium is preserved and the ejection fraction, for example, is still preserved, it's like 45 or above percent the ejection fraction, with no heart failure, no congestion, we could perform the operation even the cardiac enzymes are still high and not regressing very fast. For example, if we have a patient, with a what's called a preserved myocardial infarction and left main, and he's having cardiac enzymes which is very high, so this patient also is candidate for operation. I'm just trying to give you some examples of the patients or the experience we are facing. For example, if you have a patient who's having a very dilated heart and he's in severe heart failure and he's having critical lesions, and the family they see or some of the families, they having some doctors in the family, and they are saying, we see this coronary angio and we know that the lesions are so critical, so go on and do this surgery. No, we don't have to follow this. Even I know the lesions are very critical and the patient is still in danger, but I shouldn't follow this, and I have to wait and be patient. So the clinical picture of the patient or the clinical situation of the patient should be judged also. If the patient is stable, the heart is not dilated, the patient is not failing, he's not congested, it's okay, we can proceed and go on. But for the time frame, we don't have exact time frame for any patient for any single condition. Even, for example, some of the patients who are having left main and critical left main, some of these patients are having recent infarction and their myocardium is very bad. So I have two options: either to submit them for surgery or to wait. The decision in these patients is the most difficult situation. This is the most difficult situation. Left main patient with an extensive infarction and unstable, what to do with this patient. In this patient, you have to evaluate and take a decision. The decision in most of these patients is almost very painful. Not difficult, is very painful, because if you waited and the patient suddenly arrested, خلاص, you lost the patient. If you submit him for surgery in such condition, mostly he will not come out from the OR. So this is the most painful condition in our practice of surgery.
Field. Yeah. Thank you, Dr. Ashraf.
Welcome.
We have a good collection of questions for the two presentations. I will take one by one to gain the most benefits from these topics. First question to Dr. Osama. He is from Dr. Saud al-Sahli. He said, what if ST elevation was about 15 or 10 minutes? We call it STEMI or non-STEMI?
Yes, I saw this question actually. It was a very tricky question. I mean, to be honest, we have to, the guidelines are there to tell us what to do, to guide us about what to do. And the guidelines are very clear, like 20 minutes, more than that is ST elevation MI, less than that is not ST elevation MI. And the reason is, don't forget that a lot of patients with coronary spasm do present with angina and ST elevation as well. But luckily that these people, usually the ST elevation doesn't last more than 20 minutes. So it's usually a few minutes and the ST segment disappears. So we have to stick with the guidelines. But that's a very tricky question, Doctor.
Okay, second question also for Dr. Osama, also from Dr. Saud al-Sahli. He said, what can we do to improve the mortality for patients with non-STEMI? Is not better to advise for new guidelines or modified guidelines to be suitable for these type of patients?
Excellent again question by Dr. Saud. Now we have to know that first of all, the studies that were conducted in non-ST elevation ACS, or historically the non-ST elevation in my patient in the past, we tried everything. Like we almost tested every single thing. I'll give you an example. You know, the reload trial. Like even we tested which one is better, like the loading dose of clopidogrel, for example, is 300 better than 600, 600 better than 900. So honestly, like I don't think there is anything that or a medication that might change the prognosis of these people. These people, we have to know that they are they have a very sick endothelium. They have very nasty diffuse disease. They have a very unstable plaque. They can easily go into distal embolization. All the thrombotic complications might happen in these people. Most of them also have a low ejection fraction as well. So that's why it's better all the time. As I totally agree with Dr. Ashraf that for him, we have to, from a surgeon perspective, we have to take things easy and sit down with the patient, tell them that it's better in the interest of the patient to wait and not to rush. I think same applies for non-ST elevation ACS. Give them good chance on medical therapy, stabilize the plaque, let them be in the best shape possible, and then you do revascularization accordingly. And early recognition, if we just stick with the guidelines, inshallah, I guarantee that these people will not be missed. But the problem is we're still, unfortunately, missing lots of non-ST elevation ACS in the emergency department.
Great. Thank you, Dr. Osama. Another question he said about what about asthmatic patient? I think he may be talking about beta blocker.
Yes. Again, a great question. We know that patient with moderate to severe COPD, reactive airway disease, there's so many studies that were done on these people, and they were mainly for heart failure trial, mainly heart failure reduced ejection fraction. And it when the beta blocker was in the late 900 and in the 90s, I believe. And it was shown that a lot of these people, moderate, severe asthma, reactive airway disease, or even advanced COPD. You know, even there are some studies that looked at patients who are on home oxygen, still tolerated beta blocker. You never ever stop doing it, at least you give the benefit to the patient. And if the patient fails, then you fail. That's something acceptable, but never ever try to not to give them the benefit of the drug.
And I think we can start by selective ones and start slow and low dose.
Oh yes,
and
absolutely.
Yeah,
Absolutely. You know, to be honest, the most like now the indication for non-selective beta blocker carbidopa is if you have someone with heart failure and peripheral vascular disease. These are people who benefit from the vasodilator effect of the carbidopa, not like the other type. But other than that, to be honest, I think all patients should be getting selective beta blocker. It's a good point to say.
okay, thank you, Dr. Osama. This question for Dr. Ashraf Fawzi, the question said, what if the patient and after BCI and the decision taken for CABG and the patient loaded by antiplatelet therapy, especially if it is ticagrelor? So what is the decision?
The decision is more wise to postpone, because sometimes in such cases, we are going to lose the patients from bleeding or blood loss and not from even correction or uncorrection of the ischemic event or revascularization. So what I mean to say is being more wise. It's not because in the last 2 decades, since 2 decades before, most of the studies and most of the surgeons were, and even the cardiologists were encouraged and to take the patient very rashly inside the OR to perform what's called urgent revascularization, whatever the condition of the patient. Some of the patients are receiving thrombolytic therapy and they are having bleeding, very high bleeding tendency. And we lost a lot of patients at this era by this technique. And even some of the patients, their myocardium is so friable. So if you manipulate the patient, some of the patients, even with the manipulation of the myocardium, is perforated. And I had seen this in many centers I had been working before. The myocardium is so friable, even you touch it like this, khalas, the patient is lost. So being wise is the most recent trend in most of the studies. Don't be pressured by anyone who is pushing you to do, even the patient is unstable. Even if the patient is unstable, or you are seeing there is arrhythmia, there's some bleeding or ecchymosis under the skin, so you are saying, we are going to lose the patients. No, you will lose the patients if you admit him to the OR. I think my answer is clear. Or
clear? Yes. Another question, Dr. Ashraf. You said that time frame for CABG is variable. So what's your opinion if the patient had hypotension and depressed ejection fraction after acute coronary syndrome, and the patient had stunned myocardium? If we postpone the surgery and the patient need revascularization, what is the burden on the myocardium? He will gain benefit after surgery?
The time frame in most of the patients, especially in the Middle East, is it's unknown. So the patients most of the patients are coming to you in a time frame which is actually, it is not known. He doesn't know even him, and most of them, they are diabetic and they don't know when this started exactly. Some of the patients, they are coming within 48 hours or 24 hours of the start or the onset of the event. So you are diluted, you are what's called, you are biased. There is a bias. You don't know when the event started actually, so you will be transferred from this group to another group without you actually know what you are doing. So it's so dangerous. If the patient is unstable, hypotensive, and the myocardium is very bad, so what is the benefit if you take him to the OR in such condition and you inserted an intra-aortic balloon to him to just to assist him, to help him? What we saw before, such patients, they have very, very, very high mortality. Very high mortality. If you stabilize the patient, this patient outside in the CCU, you have what's called two exits. One exit that this patient will deteriorate, and the other that this patient will have time to recover. I know he will lose some part of his myocardium, but losing some part of his myocardium before the definite revascularization is better than to lose his life. And this is the trend of most of the studies now. Don't rush to it. Even some centers, they prefer to postpone the patient for up to more than 3 weeks. More than 3 weeks. If you couldn't decide well the patient event, the acute event, when it happened, and the patient is having good myocardium and his hemodynamic stable, don't admit him to the OR. You are killing the patient.
Okay, thank you, Dr. Ashraf. There is a good question from Dr. Sahar. She said, thanks for the interesting lecture. What's your opinion about revascularization in patients with COVID positive? And we are facing these cases daily.
For me, or revascularization by BCI?
Dr. Osama Al-Hadrami.
Oh, okay. So revascularization for COVID patient, that's the question. Now, it depends on what kind of patient. Are we talking about ST elevation MI patient or non-ST elevation MI? In patients with non-ST elevation MI COVID cases, and that even that was the guidelines and the recommendation from the peak of the COVID era last year. In most countries and most guidelines, they still recommend to follow the non-ST elevation or to treat the non-ST ACS COVID case the same strategy as we are dealing with non-COVID ACS, non-ST elevation ACS patients. Yeah. Because here we are not talking with emergency or urgent revascularization like STEMI patients. Now, the difference was the STEMI patient, in which most of the early guide, like the recommendation, were recommended through thrombolytic therapy for STEMI patients, just to minimize the contact with the patient. But that happened, I think, in most, because I published a paper about this a few months ago. That took place until probably June, July of 2020. And then after that, all tried to apply the STEMI guidelines for COVID cases, same as non-COVID cases. But for non-ST, both the same.
Thank you. Another question for Dr. Osama. What's your opinion about using of rivaroxaban small dose in patients with non-SCT acute coronary syndrome? Is it beneficial?
Yes, this is an interesting question. So now rivaroxaban is first of all, we have to know why the indication. Is it for to use it as like an anticoagulant for AF, for example, it has its own guidelines, and how do you deal with it on top of a dual antiplatelet therapy. But I'm sure the question is about using it as a secondary prevention strategy, and it is absolutely yes, correct. It can be used as a secondary prevention strategy. So only if you use all class 1 indication medication, the antiplatelet, that you have put them in proper antiplatelet indication, then yes, you put them on rivaroxaban. And by the way, it's only rivaroxaban. That's the only one that has been approved for secondary prevention anticoagulant. With top of the antiplatelet therapy at a dose of 2.5 milligram only, not more than that. And it has a soft indication, so I think it's class 2B, if I still remember. Definitely not in the top. You might use it, and only after you fulfill the class 1 indications.
Yeah, great. There is a tricky question for Dr. Ashraf. One of the nightmares in cath lab is aortic dissection. So what's your opinion of the patient during intervention? He developed aortic dissection with multi-vessel disease, and he received antiplatelet therapy. So what's your decision?
It's يعني like طيب. No, the dissection it's happening after the PCI or before?
He said during
if he will make a trick for me, I will make a trick for him. you already make the stenting and the patient is revascularized well, and there is a dissection going on. And what is the kind or the type of dissection? It's type A or type B?
That. Yeah.
Huh? It depends.
Not mentioned.
It depends, as we said. But by the way, what I mean to say, a consensus in scientific communities is a very perfect issue. But we have to know something, that the consensus is not applicable in some situations, and it's specifically not applicable in the rule of surgery, in acute coronary syndrome. And there is no time frame. As I said before, in the previous 2 decades, or exactly in the 90s, most of the surgeons are rushed to the OR, and this is so risky. No. So I'm answering to this question. You have to specify because the management will differ. If the dissection it occurred after or before the PCI, or the type of the dissection, and accordingly we will decide what we will do. Because now we have the interventional issues of solving the problem of dissection, so it's not a big deal. So also it's a challenge if something like this happened and we have to interfere surgically. It's a challenge, but we have other alternatives. So the answer, it depends on what happened and when it happened.
Okay, another question for Dr. Ashraf. You mentioned that one of the limitations for the going to bypass, if the infarct area is small size.
It's not a limitation. It is not I mean the size of. I didn't. Sorry if you misunderstand this or misinterpret this. The size of the infarcted area. What I mean, if it is small infarct area, so we can proceed for CABG. If it's a very big area like extensive myocardial infarction, it's so dangerous and so risky to proceed for CABG. So you have to wait, even or despite the drawbacks of remodeling. So what we have to do, you have to submit. You have, as I said, you have 2 alternatives: to submit the patient with a very friable myocardium. Even if you do this on pump or off pump, it is the same, because even in off pump you are manipulating the heart, so you can tear the heart into pieces. And even if you went on bypass, there will be more edema to the myocardium and more insult to the myocardium, so more death to the myocardium. What I mean to say, the size, and this size, it could be judged by the ejection fraction or by the decision of the cardiologist. He's telling me this area is a small infarct, this area is big, so I have to, it's, as I said before, it's a matter of discussion between the heart team, which is the cardiologist, the CCU, the anesthesia, and the cardiac surgeon. What I meant, which is hindering the decision to admit the patient to the OR, it's a big infarcted area, not a small infarcted area.
Thank you. This question for Dr. Osama. The immediate invasive strategy for cases of non-SCT acute coronary syndrome. What's your opinion about post-arrest or patient on mechanical or who had mechanical complication? There is a great debate between different areas about that. You will proceed for intervention or you will wait and see the conscious level of the patient. What's your opinion?
So that depends on the are we talking about witness cardiac arrest, out of hospital cardiac arrest? That it depends on the situation. Now, most of the patients who come out with acute coronary syndrome, whether ST elevation MI or non-ST elevation MI, the cardiac arrest happens quickly, and most of the time is witnessed. You definitely it's a class 1 indication to proceed for early invasive strategy for non-ST elevation ACS if you have a life-threatening arrhythmia. In fact, if you look at the GRACE score, they give patients with a cardiac arrest probably the highest risk, and it gives them, like, I believe, 34 points more in the GRACE score. So that by itself increases, dramatically increases the risk, and it makes the justification of early revascularization is even more indicated. Now, the problem is that we face all the time is out of hospital cardiac arrest, unwitnessed cardiac arrest, when a patient comes in like after 90 minutes of CPR. And to be honest, that it depends on the underlying situation. I'm sure most of my colleagues will definitely take the patient to a cath lab if there is like an obvious ST elevation, and we do this all the time. We give them a benefit of revascularization, because you never know. You cannot just keep waiting until the patient regains consciousness. It might not happen until like maybe 2-3 weeks to see some neurological symptoms. So it is very highly individualized decision.
Great. Thank you, Dr. Osama. Dr. Ashraf, do you agree for the cases of unstable angina on top of coronary syndrome to do and plan for CABG, to do viability study for all these cases before going to bypass?
And he means with low ejection fraction or good or preserved ejection fraction. I don't understand the question well. It's a chronic
let
syndrome.
Us talk about low ejection fraction.
With low ejection fraction, يعني it's better to do a viability study. But يعني from my humble experience also, what I mean to say, in some patients with very low ejection fraction, like 25 or 35, between 25 or to 35 or something like this, and they have critical lesions, and they are not amenable for PCI, but the targets are good. So in your opinion, the one who asked this question, in a case like this with good targets and a very low ejection fraction, what we have to do? I cannot hear you. This now I'm forwarding the question to the one who asked it. What we have to do.
let me play the question. Let me play the
Dr. Osama, considering we don't have feasibility for viability study.
Yes. So let me. So just imagine I'm the one who asked the question. So yes. The question is, which is a very excellent question. Now, yes. I in the cath lab, I have a patient coming with a massive anterior wall MI. Okay. You already see that there are a lot of Q waves in the anterior wall, and he has like severe left main or vessel disease. Okay. And we agreed the patient is a surgical candidate, and now we see Q wave in the ECG and an echo next day that showed the ejection fraction of 25%. So are you willing to take a patient with a Q wave ECG and EF 20% and give him revascularization surgically or not? Because you have to know that our patient, like if we open arteries like this, I mean, these people usually have an infarct anterior wall. So yes, or wait, or do viability.
Yes, I said I agree. I have to do viability study, but I mean now, for example, if you don't have any feasibility for such cases, and I tell you something from my experience. And this is, I think, it is very nice thing. I will tell it to you. Yeah. I look to the X-ray of the patients. Even the patient is having low ejection fraction and is having a small heart in the X-ray. And notice this. And he's having good targets with low ejection fraction. I am encouraged and I'm willing to do such cases. This is a personal experience. I cannot generalize it. Or I cannot say it is something sharp scientific issue, but this from my humble experience, I can tell it to you. But for my answer, my answer to this question, there must be a viability study. But I'm just discussing and arguing with the one who asked this question.
Yeah, and thank you, we have to keep in point the two terminologies: the hibernation and the stunning. Yes. So both of them, like these people might just have no uptake, absolutely non-viable myocardium, but they are in the process of hibernation. Of the stunning. Yes. Yes, and they will definitely recover, or with time they benefit. So I totally agree with you, Dr. Ashraf, that sometimes you just need to do it, whether they have Q wave or not. Because the same thing I'm going to do in the cath lab. I'm going to put a stent in that territory, whether they have Q wave or non-Q wave. Hopefully, it might be a stunning or hibernation.
Yes.
I think Dr. Osama, thanks for this fruitful lectures, but I think the question comes from the STITCH trial, and he asked about, as regard the STITCH trial, says that no need for viability study, but the default in this trial, it is done under not use the PET scan or MRI, which is the best method for viability. So STITCH trial is still debatable. So we need already to do viability study for low ejection fraction patient, less than 35%. Thank you.
Great. Great. Last question for Dr. Osama. Acute coronary syndrome is appeared nowadays too much in young ages. So what's your recommendation or advices for that?
You know, the ST elevation in my patient, the angiogram that they showed was like only left circumflex artery disease. That was an angiogram of patient with 27 years, smoker only. Just imagine that belongs to a 27 years old. I'm still following him in the clinic. Yeah, he's doing great on medical therapy. Now, this is really a problem, and the problems or the challenges that come with this is we are missing few important screening tools in our community. And probably the most underestimated or unrecognized risk factors in our community, which I see often, and also a lot of my colleagues share this concern, is familial hyperlipidemia. These are the people who have probably the highest risk of atherosclerosis, because their atherosclerosis start from when they are in the uterus of their mom. All right, that's as early as atherosclerosis they're going to have. Unfortunately, these people, and you know what, compared to our the few of my colleagues here in Saudi Arabia published data about familial hyperlipidemia in our community and in the Gulf region as well, in one of the registries, and our prevalence is almost double than the standard, or what do we know in the or what we know in the community in the Western societies. So and a lot of them unrecognized. So these people should be authorized. We have to have a very strict screening protocols, not only for diabetes and hypertension, but we are missing a lot of hyperlipidemic patients. And the second group who are quite frequently missed are those with high genetic family history of atherosclerosis. And don't forget also coronary anomalies and dissections. Coronary dissections can happen in this age group, but you never predict who's going to have really a coronary dissection or anomalies. But at least for genetic family history and familial hyperlipidemia, we should never miss these people. And that's what I do for all for that patient. I did a family history, like a familial hyperlipidemia screening, and interestingly, the insurance company kindly agreed to send all the familial hypercholesterolemia FH screening to Europe, and they came back positive. So once you recognize such a patient, you have the first thing you have to do with that. Please bring all your siblings. You need to see your brothers, your sisters, everyone in your family to screen. That's the only way. It's like, you know, when we identify COVID cases and the tracking that we do, FH, familial hyperlipidemia, should have the same identification process. Dr. Zenhom, you need to open the mic.
Thank you, Dr. Osama, for these nice answers. I am very sad to say that we reached to our end of the symposium today, but not all. I would like to thank deeply our magic intervention cardiologist, Professor Dr. Osama Al-Hadrami, and our pioneer, Professor Dr. Ashraf Fawzi, for those nice presentation today. And also, I would like to thank all the colleagues and the attendees who attend our symposium today. This is the first day, and as we noticed, the information we had got today is very important. And every day we have new update in the guidelines and in the treatment, in the protocols of management. So thank you for all, and we will wait for you tomorrow, inshallah, at the same time, 8 p.m. KSA time zone, to enjoy another 2 topics about acute coronary syndrome. Thank you for all, and see you soon.
Thank you so much, guys.
شكرا.
Good to be with you. شكرا لك.
السلام عليكم.
عليكم السلام.